and then the second dose is next month. And that means that as a state, we're really turning our full attention now towards our ambitious goal of vaccinating at least 70% of Coloradans 70 and up by the end of February. 530,000 Coloradans in that category. People over age 70 represent 3/4 of the deaths in our state and just over 40% of the hospitalizations. So by protecting those who are at greatest risk, we can end the crisis phase of the pandemic. The pandemic doesn't end until we have broader vaccination, but the crisis phase ends. We're no longer talking about exceeding hospital capacity, deaths, even in major outbreak periods, reduced by 3/4. And we look forward to updating accordingly. And I know that for some Coloradans over age 70, they're frustrated and confused about how to get the vaccine. While many have gotten it, I understand that others might be on a list and might wonder why they haven't been called yet. It's simply the numbers. We get 70 to 80,000 vaccines a week. There's 530,000 Coloradans over the age of 70, most of whom want the vaccine or eager to get it. So if you're over 70, you may have gotten the vaccine. You may get it this week. You may get it next week. You may get it the week after next. But you will get it. But the limitations on supply mean that it's not physically possible for everyone over age 70 to get it this week or even next week. So I've been encouraged so far by our conversations with the Biden administration and their COVID team on the future flow of vaccinations, but there's nothing that we can take to the bank yet. I have a call with NGA, National Governors Association, and the Biden administration later today. We'll certainly update you on what they say, but we cannot yet count on additional supply yet. We hope to be updated soon with what that might be, and we will adjust our plans accordingly. As I said, we have the ability to deploy several times, 3 to 4 times with our current infrastructure, and we have the ability to have surge infrastructure using the National Guard and FEMA and others to deploy 5 or 6 times as much per week without a lot of difficulty, but we simply need the vaccines. We also, as you know, are launching the first large-scale drive-through facility at Coors Field, and I want to thank UC Health for that partnership. We did a great trial run. 1,000 Coloradans over age 70 got vaccinated. This coming weekend, they're going to be doing 10,000 people, which is great. And again, just to put people say, why aren't there more of those sites? Well, put that in perspective. We get 70,000 vaccines, and they can do 10,000 a day at one site. They could literally use all the vaccines we get in the entire state at one site. And that's not an answer for our whole state, because we don't want to use all 70,000 at Coors Field. They need to be in Grand Junction and Pueblo and Colorado Springs and Lakewood and Fort Collins and Greeley and Sterling. So it'll play a role, and we're excited for Denver metro area residents to be able to have that scale. And if the supply increases, it's certainly possible there'll be 1 or 2 others, but they certainly can't take the place of community, small and medium scale vaccination clinics. Some of them drive through in church parking lots and recreation centers, others at community health centers, hospitals, and pharmacies across the state. If you're interested in signing up to receive the vaccine this weekend at Coors Field, or anywhere else, you do need an appointment. They don't take walk-ins. That enables them to make sure they schedule your second dose. And there's no preference whether you're currently UC Health patient or not, no matter what your insurance is, even if you don't have insurance, doesn't matter. None of that matters for this. You can sign up at www.uchealth.org/COVID vaccine to sign up for the Coors Field Super Clinic, or call their vaccine hotline, 720-462-2255. Again, if it works well with increased supply, we hope there's even more of those. So if you sign up and you don't get called for this one, hopefully they'll be back next weekend or even for extended days. But it's exciting. The 1,000-person clinic went very well, and we're very excited to do the 10,000-person a day clinic at Coors Field, along with all the efforts across the state in pharmacies, community health clinics, and hospitals, and many other partners. We are also prioritized on equity, as you know, in addition to the work that major providers are doing to reach out to all Coloradans, like the mass vaccination events. We're partnering with community health organizations to ensure that we're connecting with medically underserved Coloradans, hard-to-reach Coloradans. This month alone, we've stood up multiple drive-through vaccination events for Coloradans age 70 and older, whether it's the partnership with Valleywide Health to vaccinate hundreds of Coloradans in San Luis and Center, working with the Ministerial Alliance and Zion Baptist to vaccinate 100 congregants over 70 in Denver's Whittier neighborhood. La Plata County vaccine drive to reach Colorado 70 and up in southwest Colorado. We worked with the Church of God of Christ, God in Christ in Aurora to vaccinate over 200 people over 70. So these kind of targeted outreach efforts are going to be extremely important because we understand that everybody isn't ready to sign up online or go to a hospital or go to a pharmacy. But for most people, it'll be hospital, pharmacy, drive-through clinic, sign up online. If you haven't been called yet and you're over 70 or signed up your mom or your dad or your aunt or uncle, if they don't get it tomorrow or the next day, they're very likely to be called up next week or the week after. We really expect that most of the 70 and up in the next few weeks, with the supply we have, will have that opportunity to get the protection. So if you are 70 and up, if you have a mom or dad or aunt or uncle 70 and up, to help them, simply go to covid19.colorado.gov and click on information for vaccine providers. And then you can schedule an appointment, set one up, sign up on a wait list. If you live near several, you can sign up on several and be able to get that vaccine sooner rather than later. No, look, vaccines are the path back to the Colorado we know, we love, to normalcy. Today, Dr. Herlihy is going to share more information on how they impact modeling data. So right now, remember, I think we're one of the top 10 states or so on a number of people vaccinated. It's still only 7 or 8%, and that's only the first dose. Second dose is less because there's a month lag, 2-3% of our population. So it's only just starting to have a very small impact on the overall epidemiological data. But Dr. Herlihy will show what that means as more and more people get vaccinated, especially those who are most likely to require hospitalization or to have major adverse health effects from COVID-19. What I think overwhelmingly the data will show is just why it's important to do what we know works to continue to slow the spread of the virus. Wearing a mask, avoiding social gatherings where possible, keeping a distance. Just these same measures that have got Colorado through this are really the most effective way we have to get through the next few weeks and months as the vaccination rapidly kicks in to save lives and end the pandemic. Our two goals with vaccination: save lives, that's why 70 and up, most vulnerable, end the pandemic rapidly as more people get vaccinated. March, April, May, you'll see how that impacts the overall status of the pandemic in Colorado. So with that, and without further ado, we'll turn it over to Dr. Rachel Herlihy for a very important update.
Good afternoon. Thank you, Governor. So today I'd like to provide an update on our case counts and our hospitalization data, and then also talk a little bit about how Colorado compares to other states as far as cases and hospitalizations, and also talk about some of our modeling data and what we are looking at right now, specifically looking at the impact of having a greater population in Colorado vaccinated over time, and then specifically also looking at the potential impact of a variant like the UK B117 variant and what that could potentially mean for Colorado. But starting here, this figure shows you our daily case counts in the state. So each of those gray vertical bars shows you daily counts of cases. We also here show you our 7-day moving average, which is that dark red line, which helps smooth out some of the data and helps us see a little bit more clearly some of the trends over time. So in looking at this figure, if you look to the far right, you can see a clear increase that was associated with Christmas, New Year's holidays. But since that time, we've been on a steady downward trajectory. Really about the last 2 weeks or so, we've resumed our downward trajectory in the number of cases that we're seeing in the state. So certainly things are looking much better here in Colorado. And then next slide. We're also seeing a similar downward trajectory in most states across the country right now. So overall, U.S. numbers are going down. But this particular figure shows you Colorado's position compared to other states across the country. And so states are ranked here based on their 7-day cumulative incidence or rate of disease. So how many cases occurred per population over the last 7 days. And what you can see here is that Colorado is obviously doing quite well compared to other states. We are 11th in states for the lowest rate of COVID-19 occurring across the country right now. So that's certainly a position that we are happy to be in right now. I'd caution, though, that rates, of course, continue to be high. We know that even though we're moving in a downward trajectory, that there's certainly plenty of cases. The governor mentioned 1 in 115 individuals currently infectious. So the strategies that we're using are obviously still important right now. Next slide, please. So this specific figure shows you a similar trend. So this is comparing hospitalization data for Colorado and the US. So you can see that Colorado, again, has done quite well. Our hospitalization rates are much lower than US rates overall. You can also see that we started to decline. Our decline in hospitalization started sooner than the overall decline in US hospitalizations. But obviously it's great to see here that the US has also turned a corner. And in the last week or so, we have seen a downward trajectory for hospitalizations and cases in the US overall. Next slide. So turning to some of our modeling data. The two topics that I want to cover today are one, the potential impact of vaccines and what that might look like as far as cases, hospitalizations, and deaths in the state. And then second, the potential impact of a variant that could enter the state. So specifically, the variant we're going to be looking at is the UK or B117 variant. What we know right now about that variant is that it appears to be more transmissible. There's also some early data that suggests that it could potentially cause slightly more severe illness in individuals, but that data is pretty limited at this point. We're obviously also paying close attention to other variants that are emerging in other parts of the world that could potentially have other impacts. But at this point, the variant that we are tracking most closely, this B117 variant, doesn't appear to have an impact on vaccine efficacy, and that's obviously really important, and that'll show up in the data that we're showing today. So starting here, looking specifically at the impact of vaccine in the state. So what I'm showing this figure here is 3 different levels of transmission control. 78%, which is our current level of transmission control. And when I say transmission control, that really refers to all the strategies that we have in place right now to suppress the virus. So social distancing, wearing masks, namely. But what this figure shows you specifically, if you compare the blue bars and the gray bars, is the overall impact of vaccine in saving lives here in the state. And so you can see clearly that introducing vaccine and our current rollout of vaccine is going to save lives over time. And this figure is looking specifically at the number of lives saved by June 1st. The impact becomes larger if we see less transmission control happening in the state. Next slide. But I want to highlight here for you the fact that if we maintain our current level of transmission control at 78%, that is really where we see the greatest impact on saving lives here in the state. So compared to lower levels of transmission control, which really means lower levels of social distancing and lower levels of mask compliance, if we're able to stay where we are right now at 78%, that's really our best chance at minimizing the number of deaths that occur over time. And this is really because as we go through the next couple of months, we're not yet at a place where we have herd immunity or population level protection. And so while individuals that are vaccinated are being protected, we really don't see the full effect or benefit of the vaccine for many months to come. And so during this time, all of the strategies that we have in place really continue to be important for months to come. Next slide. Turning now to looking at the potential impact of a variant in the state. So again, we have 3 different scenarios here. Our current level of transmission control, which is 78%, and then 2 levels of lower transmission control, 70% and 60%. And so here what we're doing is comparing the difference between our current trajectory with vaccine introduced with no variant widespread in the state, and that is shown in green. And then comparing that to if a variant were to become widespread in Colorado, and that would be shown in blue. And clearly here you can see the difference between the number of hospitalizations specifically being shown in this figure that would occur by June 1st if we were to have a variant introduced in the state. Obviously, the impact is much greater if we see less transmission control, meaning that variant could potentially spread faster in the state. But again, I think the take-home message here is that if we're able to maintain our current level of transmission control, so social distancing, mask wearing, for the next few months, at least through June 1st, that's really our best way to limit the impact of COVID-19 in the state, specifically, the impact of a variant as well. So again, continuing to recognize the importance of the ongoing strategies we have in place now to prevent hospitalizations and deaths from occurring in the state. Next slide.
Thank you. So, and of course, we hope that there's a large-scale vaccination before June 1st, but we just don't know those dates yet. It's right now 80,000 a week, but if the Biden administration succeeds in 100 million doses in 3 months, that's roughly 1 in 4 Coloradans, 1 in 4 Americans, translates to 1 in 4 Coloradans. That would start having a profound impact on ending the pandemic, and then hopefully the following 100 days would be an even greater number than that first 100 million. Just the other day, the Biden administration, the president himself expressed optimism that by early summer, and everybody who wants a vaccine will be able to get it. So if that's the case, and they certainly have more visibility on supply than us, then the pandemic might end sooner rather than later. But at this point, we are all waiting supply figures. We're doing everything we can with every dose here to save lives and end the pandemic. We really can't let up now. We're here in mile 23 of the marathon, and we just have to make sure to finish it strong and double down here and be cautious and careful in the final mile to protect ourselves, wearing masks, staying 6 feet from others, limiting social interactions whenever possible to those in your household. Look, we may be in the home stretch, but there's still a lot of loss ahead. As you saw from these models, we could lose hundreds or thousands of Coloradans who very likely will die from this deadly virus. And how many exactly is really in your hands. It's how well we do the social distancing over the next few months. If we can keep it up the way we are now, we can minimize the losses. If we revert back to what led to the huge increases in October and November, we could lose 5, 6, 7, 8,000 more people. If we're not careful, there could even be more loss ahead of us than behind us. So let's keep doing what we've been doing. Let's stay on this path. The vaccinations are rapidly catching on, protecting the most vulnerable, 70 and up, and then, of course, 65 and up, teachers and essential workers, as soon as we get the supplies that allow that. And we can do it together, Colorado. So with that, happy to answer questions.
Steve Stager from 9 News. We've heard from people this morning saying that they are having trouble after making appointments, that they've been turned away from pharmacies in several different counties just because they don't live there. That would seem to run counter to what you told us last week. So are pharmacies required to administer the vaccine to people from a different county? And if they are required, do they run the risk of losing their vaccine privileges if they don't give the shot to someone?
Absolutely. Our guidance is very clear. If you're 70 and up, you're eligible for the vaccine. You can get it anywhere. Now, that's very simple in a metropolitan area. It's very likely people are going to a different county to get it. I mean, in Coors Field, there's going to be people from Jeffco and Adams and Denver and Boulder and Broomfield and Arapahoe, and probably people from Douglas and Weld and Larimer might come down there to use it. Obviously there's a lot of distribution partners in this, and yes, anybody that we find that is trying to deny a Coloradan the vaccine based on where they live, or based on insurance status, or based on any other factor that is not part of our state guidance, we will issue a very stern warning to that partner, and it could very well have consequences about our future partnership as we look towards more reliable partners to distribute the vaccine that are, in fact, giving it to everybody over age 70.
Thank you.
Governor, when you talk about transmission control, I know a big part of that is the state style framework. Right now, many counties are still in orange and yellow. So how does that factor into the charts that we saw? And is that saying that, hey, we might still be in these levels through, midsummer?
We could figure that out, but wherever we are at a given time is where we'll be on the dial. There are two things that are relevant to kind of the dial that I want to talk about in the future. One is there will be some updates that are just based on our experience with the dial that we put out in draft in the next couple days, and they'll be common and they'll be implemented. These are not major changes. They're simply based on the experience of several months with the dial. But there will be more substantive changes to the dial, and we're beginning these conversations once our most vulnerable are protected, right? What does the dial look like once everybody over 65, essential workers, all have protection? There will still be a need for a dial, but it will be recalibrated. And so that conversation's happening now. The time for when that goes live, early March, whenever that might be, when we've reached that protection of people over 65 and many essential workers. And then finally, the winding down of the dial. That's late spring, summer. That's the end of the pandemic. That's not where we are yet. There's not a time date for that yet. So some immediate updates on just from the learning that's occurred in the past few months. Second, where we'll be for at least a few month period where the crisis phase of the pandemic is over, but the pandemic's not over. Let's call that, March, April, May. And then finally, winding down the dial altogether. So that's the future of the dial. And it does align to kind of where these numbers might be.
Not only what we're doing with the dial, but just everything else then too.
Yeah, transmission control is the collective result of the choices people make. All right. I mean, the dial is helpful guidance. And we've talked about the public health piece being maybe 20% of the overall picture. But whether you're going over to a friend's house for coffee or your kids have play dates, all those personal decisions people make, that's what in the aggregate leads to this social distancing number. So the way we've been living the last month has worked. It's put a downward trajectory in the virus. If we can keep this up for a couple more months, we can minimize loss, get back to normal sooner rather than later, and give the vaccine a chance to catch on without risking overcrowding our hospitals.
Hello, Governor Polis and Dr. Herlihy. This is Untitled Chapter at Bloomberg News in Denver. The variant first detected in Elbert County, where did it come from? Could it occur spontaneously, or is it from the UK, maybe via DIA? And I have a follow-up.
Thanks, I could take that question. So, we have robust case investigation and contact tracing efforts underway. I think as many of you know, that those specific first two cases that we had, those individuals did not have a history of international travel, but we know that we believe this variant is really being spread from person to person. So it's quite possible that at some point someone came to Colorado from an international destination, and that's how that variant was specifically spread to those individuals. And as we identify more and more of these cases in the state, it's more and more likely, just as it is around the country, that these cases are individuals that have not left the country. The variant is going to, we believe, increase as time goes on. I think we just don't know at this point how rapidly we might see that variant increase. And obviously what we need to do right now to minimize how quickly we see this variant spread in the state and in the country is to maintain all of those things that we've been doing the last couple of months that have been successful. So social distancing, mask wearing, all of those strategies that have been working for us.
Yes, sir, I do. Control, containment, many months to come. Are we talking about another year heading into 2022? Thank you again.
No, we're not. When we talked about 100 million vaccines in 100 days, if that in fact occurs, you have a quarter of our population protected, including the most vulnerable. That's why there will be an update based on now the most vulnerable being protected. Death rate declined by 75% or more. No longer a threat of overcrowding hospitals. Still loss, still people being infected. The virus can take, people of all ages. Colorado lost an 18-year-old last week. It's affected people, and there's certainly people hospitalized, and there's 20s, 30s, 40s. But once a quarter are protected, including the most vulnerable, we're in a different spot. And then, of course, as you get up to 60, 70% protected, you can begin visualizing the end of the pandemic. And while it's hard to get an exact crystal ball date on when that will occur, I still think that you're able to reach those numbers in early summer, assuming that the quantity of the vaccine increases substantially.
Herlihy, can you explain if the numbers that you showed regarding deaths are among people who have COVID or deaths due to COVID? And then Governor and Dr. Herlihy, I was wondering if you guys could share if there's been any vaccine providers who you've had to issue a stern warning to, or if you had to pull those partnerships because of issues that have arisen.
Sure, I can take the first question. So the modeling data is based on deaths among COVID cases that occur.
And as you know, I usually report out deaths due to COVID every day. The actual number is likely somewhere in between. Deaths due to COVID is we've lost just over 4,500 people to COVID. The deaths with COVID is about 1,000 higher. Some of those were unrelated to COVID. Person just happened to have COVID but died in a car crash. Others might have been related to COVID. But I always cite the lower number of deaths, deaths from COVID as how many people we've lost due to COVID, just to inspire universal confidence so people know. But obviously it is likely a little bit higher than those numbers that we cite, because it was a contributing factor in some of those other cases, for sure. What was your second question, Jesse?
Has issued any stern letters to vaccine providers or pulled any partnerships because of mishandling of the vaccine?
Yeah, I'd say the bigger problem that we encounter is not the denial to people outside of county. I'm sure that's occurred somewhere, and if we hear about it, we will react. The bigger problem has been vaccinating people out of sequence, meaning instead of over 70, there's been a few instances where it's been given to healthy 30, 40, 50-year-olds that were not consistent with the state priority list. So we take that very seriously, because every dose that goes from somebody that has a 300 to 400% higher likelihood of dying from COVID to somebody who's lower risk from COVID is potentially costing Colorado a life, a mother, a father, an aunt, or uncle. And so we certainly take that very seriously. There's a real reason, and there was a recent modeling done at CU, that the strategy of focusing on 70 up is the best way to maximize the number of lives saved in Colorado by a significant margin. So we want to make sure that all of our partners across the state focus on that group. There is a caveat. We also believe that we also have a strong tenet that no dose should ever be wasted. So if there's a vial that is being used and there's a dose there, and for whatever reason the person who meets the categorization does not show up, there will be some instances when, rather than wasting a dose, absolutely it should be used on whoever is there. But that is not something that should be done systemically, but that will occur, and we absolutely support the usage of every dose if it cannot be used for somebody over age 70 at that exact time. But that should be relatively few doses.
This is Erica Meltzer from Chalkbeat. Yesterday, General Sherman said that once you get to the below the dotted line essential worker part of Phase 1B, that teachers and childcare providers were going to be prioritized. And I'm wondering if you could just talk a little bit about how you reached that decision to prioritize them above other essential workers.
So we will have more information on the phasing later in the week. Why not today? Because we need to have a little bit more definitive information about quantity of vaccine. And we expect to get that in the coming days and narrow the parameters of uncertainty. We've currently indicated that we expect that March 1st, we will be able to begin with teachers, childcare workers, essential workers. I'm optimistic it will be earlier than that, and we've also indicated that that's a possibility, but we just don't have that date to present today. We certainly believe that the continuity of education, of childcare, of schools is really a linchpin of society. Already, of course, teachers over 70 can be vaccinated. As we go to 65, everybody over 65 can be vaccinated. But we do want to make sure that even if there is another spike in the virus in the next few months, that our teachers have the confidence to be able to remain in in-person class instruction. We've had a big focus on getting them back to in-person class instruction, created one of the safest work environments that exists in our state with the multiple measures that are taken: symptom screening, mask wearing, testing up to 2 per week per teacher if they want, free masks, medical quality provided to teachers. So we want to continue to provide this very strong level of support to teachers, and that's why we moved up educators from April or May in the vaccination schedule to March, and why we also expect that with the new phasing based on actual numbers, that we might be able to move up workers, essential workers and teachers another week or two.
A quick follow-up, if I could. Would you expect that vaccinated teachers would still quarantine after exposure, or would you revise the quarantine guidelines again?
I'll let Dr. Herlihy address that.
Thank you. So we actually today shared some information with healthcare providers across the states through our Health Alert Network system, updating Colorado's guidance on quarantine after vaccination. So our recommendation in that health alert is that individuals who are 2 weeks from their second dose of vaccine would no longer be required to quarantine, but there are certain exceptions for that. Individuals that are working in high-risk settings, for instance, may be required to quarantine. So for those circumstances, we're asking those settings to consult with public health. But for most individuals, 2 weeks after vaccine, if you have an exposure, you would no longer be required to quarantine.
And so to be clear, schools are low risk settings. When she says high risk settings, it means like a nursing home where there might still be a quarantine requirement around those who have been corrections, others like that are high risk. Schools are low risk, so that would provide much greater operational flexibility for schools once those quarantines no longer need to be implemented.
When we look at that modeling data, how do you weigh, for example, this X number of percentage of people are vaccinated versus this is the number of cases? If cases get below a certain threshold, does that change things, or is this solely based on just the number of people who are vaccinated?
The dial framework looks at number of cases, hospitalizations, positivity rate. I mentioned there's going to be some adjustments in those ratios here in the next couple of days that'll be available for comment. These are projections just based on several different baseline scenarios of what level of social distancing and reduction in the disease transmission occurs. That choice is up to Coloradans, whether we can continue to wear masks, avoid socializing, keep the disease contained, or if people get a little bit more lax, it will resurge before the vaccine has a time to kick in. That's kind of what we were showing. Vaccine rapidly happening, but currently right now, a lot of danger in socializing and getting together or not wearing masks. So as more and more people get vaccinated, it'll save lives now, and then the pandemic will end sooner rather than later.
Is there a sense of relief when cases maybe hit a certain threshold? Or
well, this virus will be with humanity indefinitely. I think there will be people that die in 2022, 2023, 2028, 2035. But that's no different than other diseases that we coexist with. There's people that die of measles. There's people that die of a wide variety of illnesses. It will be a low number. This will likely be. We don't yet know the length of duration of protection, but it'll likely be a shot that needs renewal, meaning hopefully not every year like the flu shot, but maybe every 5 years or 10 years or 3 years. It's also possible that new variants will require new tweaks. But largely, humanity will have conquered this, relegated it to a rare event. The pandemic will be over. Life will return to normal, and there will just be another disease that exists in the large host of diseases that plague humanity.
Hi, Governor. Jason Grenauer with Denver 7. A question about a perceived line among seniors to get vaccines. Some of our viewers have been emailing, calling, saying, I'm much older than 70. I have a health condition. Why am I not ahead of my healthier or younger neighbors? Can you just address and clarify the idea that there's this perceived line among seniors to get vaccinated?
So everybody over 70 is equal in the consideration of getting the vaccine, and everybody over 70 will be able to get it within the next few weeks. If you haven't gotten it yet, hopefully this week, next week, the week after. And I get it. You might have signed up last week, and you might not have had the opportunity to get it yet, and it might not come up this week or next week. It might be the week after next, but you will have the opportunity to get it. It's very difficult within that age cohort, which, again, everybody over 70 represents 78% of deaths, over 40% of hospitalizations. It would be very difficult to sub-segment that. Age itself is the single largest risk factor. Of course, for any age cohort, pre-existing conditions are an additional risk factor, but age itself is the biggest risk factor. It is a more risky virus in terms of hospitalization or death for a perfectly healthy 82-year-old than it is for a 20 or 30 or 40-year-old with pre-existing conditions. And so guided by that, we've prioritized the group of people aged 70 and up to make sure that we get that done, and we will with the first dose in the next few weeks. And then, of course, we'll be adopting the CDC guidelines for 65 and up and rapidly expanding to essential workforce, teachers, and many others.
Hi, Governor and Dr. Herlihy, John Daly, Colorado Public Radio. Thanks for taking our questions. We've been getting questions from our audience about people with underlying health conditions that are younger than 70, and questions about their place in line and should they be prioritized at the top of Group 1B, which I think is where the federal government is recommending. Maybe you can talk through the thinking on that a bit.
So the people with pre-existing conditions that relate to COVID, not any pre-existing condition, right? Not the bone spur that got you out of Vietnam. That's not a pre-existing condition. Although if you did get out of Vietnam, you're probably over 70, so you can get it anyway. But pre-existing conditions that actually relate to a higher morbidity rate, all in phase 2. So that means as soon as we complete 70 and up, expanded to 65 and up, folks with pre-existing conditions will be available for the vaccination. The date we're currently using for that is March 1st. I think we'll hit that date. But there is really no excuse to divert life-saving vaccine from people in their 80s and 90s to people in their 30s and 40s who might have a pre-existing condition. The risk is much higher, far higher, not even, not 50, 100% higher, 100 times, 200 times higher based on age as a risk criteria. And so that's why it's aligned that way. We, of course, have moved up people with pre-existing conditions ahead of the general population. They are at a greater risk for any age bracket. The best way to think of pre-existing conditions is you start with the risk profile for your age group, 20 to 30, 30 to 40, 40 to 50, starts going up, 50 to 60, much higher, 70 to 80, much higher, 80 to 90. And then you have a higher risk factor in that cohort because you have a pre-existing condition. So if you are a 26-year-old with pre-existing condition, you have a higher risk factor than your average 20 to 30-year-old. But you probably, depending on your pre-existing condition, have a lower risk factor than a healthy 60, 70, 80-year-old. Pre-existing conditions is a broad rubric. The highest risk folks are likely folks that either have induced or existing autoimmune issues, meaning it could be organ transplant recipients, people on chemotherapy, or people with autoimmune disorders. There are other pre-existing conditions like diabetes that lead to a higher risk of adverse outcome for any cohort. But again, age itself is the single biggest pre-existing condition that is determinative of the outcome of the virus.
Hello, Governor. Jesus Carraquel from Noticias Univisión Colorado. Gobernador, tenemos información de que se ha confirmado un brote activo de coronavirus en el centro de detención GIO en Aurora, donde 16 inmigrantes ya han sido aislados. Desde que comenzó la pandemia vemos cómo esto ha ocurrido en gran situación. ¿Usted está tomando alguna medida para proteger a los inmigrantes detenidos en ese lugar?
Nuestro Departamento de Salud está investigándolo y está en contacto con Tri-County y estamos recaudando más información de lo que está pasando. Cuando tengamos más detalles, Connor se las dará y vamos a ver qué acción podemos hacer.
Hi, Governor. This is Seth with the Gazette. 2 questions. One, and maybe I'm just being stupid, I'm kind of unclear on where the 65 and up population falls in all of this now that kind of teachers and childcare workers are kind of bumping up. So can you clarify when the 65 and up, where, their rough timeline, when they'll be included? And then second, this might be better for Dr. Herlihy, but just does the state have the capacity and ability to really properly gauge how widespread the variant is here now? Do we have a proper handling on it, or do we need to ramp up to that? Thank you.
Thank you. So we've indicated that we will be adopting the CDC guidance of 65 and up. We hope to have the date for that later this week. Doesn't mean that 65 and up starts later this week. We need a little bit more information on supply. Of course, it does not make sense to divert a dose from a 78-year-old to a 66-year-old, but we feel that we will have made sufficient progress on people 70 and up soon, and we'll have that date that we'll be able to expand the availability to people age 65 and up shortly. I think, sorry, Dr. Herlihy had an answer on that.
There is a second question about statewide detection of the variant, if we have the ability to understand how widespread it might be. So in the last couple of weeks, we have stood up a system across the state to receive specimens at our state lab and do whole genome sequencing on those specimens to have a sense of how common the B117 variant and other variants in the state might be. So at this point, we have identified 10, and we'll continue to do that testing at our lab. We're looking at trying to do about 100 to 200 specimens per week. And again, those are specimens that are coming from across the state.
And it's very important to see that denominator, because just knowing how many if you found 10 and you only tested 10, then oh my God, you got the variant all over. But they are finding just 1 or 2 out of 100. So it is not the widespread variant. We are doing enough testing to know that it is a small minority of cases right now. But of course, what we've seen in the UK and other places is because of the transmissibility that could increase. But right now, it is a very minor factor.
Correct.
Can you explain a little bit more about the variant, because it's already here, right? So doesn't it suggest that all of the modeling should assume that the variant's going to spread rapidly? Do you see any situation in which the variant does not become the most popular version of the disease or widespread version of the disease in Colorado, and how would that not happen?
Thanks. It's a great question, and I think a question that I think we are still trying to answer. So I think one thing that we have going for us right now is that we have a downward trajectory in cases. So we are seeing the number of cases in the state decrease, and if we can continue to have this effective reproductive number, this R value below 1 in the state, that means our epidemic can shrink. And that's really what puts us in the best place to limit transmission of this variant. It obviously also prevents hospitalizations and deaths from occurring. But really, I think we're in a good place right now. We just need to keep up the strategies we have to really continue to minimize disease transmission.
And let me put it another way. The same methods work to prevent the spread of every variant. They just might not be as effective as they were with the original virus. So these are hypothetical numbers, but if a mask is 60% effective against the virus, it might be 40% against the variant. So the same methods work: social distancing, mask wearing, avoiding social gatherings. It's just none of these methods are quite as effective against a virus that is more transmissible.
Hi, Governor. This is Patty with the Associated Press. I want to go back to the federal shipment of vaccine. You mentioned repurposing second doses as first doses, and that you're confident that those scheduled for second doses will keep their appointments. But if there's a continued shortage, can you kind of go into if the vaccine plan would change, or if you're going to cancel mass vaccination sites, kind of what would be the decision then?
Yeah, no, everybody who got the first dose should be able to get the second dose. If there is reduced flow of doses in those weeks, what will happen is some of those doses that were going to be designated as first doses to new people might have to backfill second doses. But there is no change in that we're following guidance on 2 doses. And by moving to real-time supply management, we're confident, frankly, that supplies or vaccines they're not going to get worse. I mean, we're getting the 70 to 80,000 a week. I just don't know exactly how much better they're going to get. I don't know if we're going to have 150,000 a week in 2 weeks, or it's still going to be 70 to 80. But there's no indication whatsoever from any of our federal partners that the number will drop below what it is currently. So I'm confident that at least the current levels of supply will be maintained based on all my conversations. And of course, we hope for additional dosage. So there's really no concern about that. I think it makes sense to go to real-time management. It led to a surge of 40,000 doses in this last week for first doses. Additional surge this week while moving to real-time supply management with Walgreens and CVS, our 2 partners under the federal contract.
Chris Vanderveen from 9 News. I want to switch gears just really quickly and talk about some unemployment issues. We've been hearing from a lot of people simply have been unable to get unemployment benefits or haven't received their benefits because of suspected fraud. There's been a lot of hold cases. Do you know how widespread unemployment insurance fraud is right now in the state? And do you believe that the state is really striking that proper balance between catching fraud and then putting benefits on hold to try to catch that fraud? We're hearing from a lot of people that are waiting and they're not getting good answers and they're desperate.
Yeah. So first of all, people should know that you are held harmless from fraud on your account. You will get what you deserve. I know that that's little consolation if you're dealing with fraud. or your benefits are delayed, but you will get what you've earned under that. This is a very good question, and we should pass along to Joe Barella, our head of Department of Labor. I've had several conversations with him. First of all, we did launch the new UI system just in the last week or two, much of it going online now. We feel that through the security of that system, that alone will inherently reduce fraud. This has been a big national problem in terms of fraudulent use of unemployment claims, probably aligned with the fact that there's simply more funding for it. We do feel that it's absolutely critical that we are good stewards of taxpayer money and do not allow fraudulent claims to move forward. And I understand that that can be an inconvenience when flags are raised and delay legitimate payments at times by a week or two. And you do have to balance those things. But certainly we can reassure everybody that every benefit that you have earned and deserve, you will get. And if it was delayed because of a malicious act of a criminal who tried to defraud you of identity, it is that perpetrator who is to blame. We are all doing the best with what we have to prevent fraud against taxpayers and get you your benefits as quickly as possible.
I mean, in some cases, we've been hearing of people who've been dead for years somehow getting an unemployment claim filed in their name. It seems like that, should not be happening.
No, and those are generally caught. That's what we're talking about, security measures. It's certainly possible that there are some that were not caught, but we have good security there. We're happy to have Joe Barella give you kind of an update on the security. There's even better security now with the new system than there was before. Criminals are creative in trying every way to penetrate that. And I think the biggest downside to it is not so much that the government is being defrauded. I believe that is rare and very low dollar. The biggest impact is what the last question indicated, the poor innocent folks whose benefits are delayed because there are flags in their account or they have their identity stolen and have to go through a process of restoring who they are. That is the real victim in this. But I am confident that while I can't say every case is caught, in general, these are designated early and they're identified and prevented. Thank you all for joining us. Stay safe, Colorado.